Well, thank you for that lovely introduction. As you guys can guess, I'm not as smart as a neurologist. I'm just a plain old anesthesiologist. Certainly I did move here for the Alberta Advantage. But firstly, starting off, I think, it's important for us to appreciate the Alberta Advantage when it comes to clinical practice in pain. This is one of the few places well, it's the only place in the country where you can ask for interventional pain procedures and get them done by a radiologist or a pain physician or a physiatrist, and they'll actually do what you tick off on that box. You can't get that in Ontario, you can't get that in Saskatchewan, you can't get that in BC unless they're a small select group of patients that are followed by a pain physician. So all of us in community practice, you can actually identify, diagnose, and manage these patients in the community with access to advanced pain management that not everyone else in the country has access to. So hopefully part of my presentation gets you some understanding of how to decide that for your patients in your practice and support them as they go through their pain journey. So first things first, I have not been in practice long enough to develop any conflicts of interest just yet. The second thing is the state of evidence is always low to moderate quality in a lot of the interventional management side of things. It is the case in most of pain medicine. But certainly I'll try to elucidate some of that and hopefully speak on to some of my experiences with specific patients. And finally, the last thing I've realized it's really important having started practices in pain is certainly I tend not to be the subject matter expert in any of these issues, and primarily it's my patients, because I do stuff to them that should make no sense at all, and it works. So at the end of the day, the experience of your patients is really what's important in helping you decide how to manage them going forward and how to manage them in your own specific practices. So starting off the objectives, so I'm hoping to hopefully give you a sense of identifying and selecting patients that may benefit from interventional pain procedures, specifically spine-directed procedures, a bit kind of more, I guess, more proximal than the pericranial nerve blocks. Explore some of the techniques that you have available for interventional headaches and interventional headache management. And finally, apply some amount of evidence-based practice around this side of things, and also guideline-based practice. That way you feel confident in making decisions that aren't, that are well accepted and will be accepted by the general community at large. I will say all of the procedures that I talk about are things that you guys can access in the community. So this is not something that you have to send your patients over down to the US or something crazy for, and hopefully talk a little bit about how you can access that. So the first bit of background, this is kind of that big, massive study that happened in the Lancet. I know the graphic is really terrible, but it's a reminder of the years lost to disability. And at this stage, pain is still number one, has been since 1990, and we haven't really moved the needle much. In fact, the needle's moved in the other direction, with over 15% increase in low back and neck pain being major causes for years lost to disability. That seems to be consistent across the world, but certainly more appropriate in our specific environment in North America. So let's get into the actual procedures that we have access to. So the smorgasbord includes many procedures, some of which I'm going to talk about today, and some of which are just there, and happy to answer questions about them either after the session or during the weekend if you guys have questions. Specifically, the first one, facet joint or steroid injections. We've all seen them. We've all maybe prescribed them. We've all sent our patients to get them. If some of you are interventional pain people, you've probably done them. The next step to that is really medial branch blocks. So the nerve or the innervation to the facet joint, blocking that directly, followed by RF neurotomy or radiofrequency ablation of that nerve block, of that nerve. Certainly can get nerve root blocks, epidural steroid injections, most of which are not actually described to help manage neck pain or cervicogenic headaches, but certainly are prescribed consistently and are requested by different people, just kind of hoping to get something for their patient. Greater and lesser occipital nerve blocks, which we just talked about, Botox, utilizing, say, the preamp protocol, stellate ganglion blocks, another kind of adjunct to the sphenopalatine blocks, the idea being that we can help treat some amounts of craniofacial pain. And finally, I'm going to talk a little bit about this at the end, is surgical management of your totally refractory patients with either getting occipital ganglionectomies or C1, C2 neurectomies, and certainly that's something we can access here in Alberta. On the image there, of course, we're looking at the facet joint, and really my hope is to talk a lot more about the facet joint because it is the most implicated in causing these these headaches that we're most managing in the community. So, okay, so coming out to patient selections, how do you actually select the people that would benefit from this or who deserves this? Classically, in my practice, the kinds of people that I see are people who've had, say, a whiplash injury. That may be someone who has C1, C2 injury that needs to be addressed. The other ones are kind of flexion extension or hyperextension injuries. They fall back or they fell back on a sheet of ice, walking out of their driveway, knock the back of their head, and they complain of, now, I've got terrible neck pain and I've got this headache that just goes up along the side of my head. Sometimes it's unilateral, sometimes it's bilateral, but that's the kind of patient profile that often you'll see in your practice that you may have to address with some of these interventions, especially if pericranial nerve blocks are not as effective or not providing the duration of analgesia that's required, so at least either 2 weeks or even 4 to 6 weeks. And how do we diagnose cervicogenic headache? So this is going straight to the International Headache Society guideline recommendations, and it's nice because it fits people like me who are interventionalists. So, for me, I'm like a hammer. Everything looks like a nail to me. But luckily, the evidence around identifying or diagnosing cervicogenic headaches is really based on 4 major criteria. Headache that's developed with a temporal relation to the onset of a lesion or a cervical or a neck lesion, significantly improved or is getting better with improvement of that lesion. That's often not what we see because these patients are coming to us saying, hey, I'm still in pain. Cervical neck range of motion is reduced. And finally, the headache is abolished following a diagnostic block. So you can actually use what we have access to on your radiology forms in your practices to help diagnose as much as go on to help treat and provide some therapeutic management that goes beyond utilizing just medications or conservative management. So let's start off with AA or C0 or occipital to C1 neuralgia along with C1, C2. These are the most commonly kind of problematic lesions. So C1, C2 pain is typically very reproducible and is consistent. So they've essentially taken healthy volunteers, put local anesthetic into their C1, C2 joint, and then mapped out, well, this is the area of anesthesia that you develop, even though the injection was way down below in the neck. So we can consistently map out C1, C2 to provide analgesia in the suboccipital region. Sometimes it includes part of the ear and includes the right temporal region. But consistently, if you're seeing patients that are complaining of that, it's pain that starts in the bottom of my neck, comes up, feels like it's right behind my ear or pressure in my ear, that certainly could mean C1, C2 pathology. That said, there's a lot of overlap, so we kind of have to be cautious in terms of deciding which area to go after. The occipital to C1 area, which is rarely injected and difficult to find a radiology site that will do it, is a bit more variable and often is not implicated in the reason why people are having as much pain. And in this situation, pain could be suboccipital, supraorbital, or include the entire hemicranium. And finally, I know Dr. Jarvis spoke a lot about how the C1, C2, C3 nerves interact with the trigeminal cervical nucleus. And that's the challenge here, is that we don't really understand exactly how well to target this, but at least we know that there are afferents there that would implicate this pain pathway or pain problem. Therefore, an interventional approach, failing conservative management, is not unreasonable to offer your patient. Now, these are the remaining C-spine nerves and their kind of areas of referred pain. These are a lot more consistently reproduced, and again, that same study that looked at the occipital to C1 and C1, C2 areas went on to do the same in healthy volunteers coming down to C8. This is consistent, and often patients will describe pain problems related to a possible neck injury, say largely in the head, but can also go down to their neck and their shoulder blades. This is related to the areas that are the most affected in terms of pain issues. So really, the main culprits continue to be C2, C3. Those often will include that neck pain that's identified in the greenish color. So very much so consistent and implicated. When we look at radiographic findings, that also seems to be the most commonly injured once we look at patients after they've had an injury, followed by C5-6. In clinical practice, I see this consistently. Patients either complain of, after a traumatic fall or injury, complain of pain in the neck that goes up to their head, or sometimes a complaint of pain that's kind of lower down and seems to radiate almost down to their shoulder blade. And often I'll pull out this image in clinic and ask them, is that where your pain is? And they'll say, oh yeah, that's the spot, or that's the area that it seems to cover. And that helps us determine where to go ahead from an interventional perspective. In terms of your post-surgical patients, again, so I work at Foothills. We have the largest spine volume under one roof in the country. We run 3 to 4 spine rooms a day in terms of providing anesthetics for patients undergoing spine surgery. So Albertans are getting lots of spine surgery. And the problem with spine surgery, and the spine surgeons will agree with this, is once you get spine surgery, that means you're going to get more spine surgery. So consistently identifying areas peri-surgically are very common in terms of pain issues or persistent pain issues, despite having had the appropriate decompression after having, say, a neck problem or trauma or foraminal stenosis, whatever. So certainly targets in that situation in your practice may be just areas that are kind of just peri-articular to the area that was already operated on. Something to always think about. So the physical exam protocol, this is identified by the SIS and the ASRA Pain Medicine along with the American Academy of Pain Medicine. This is kind of the accepted set of physical exam maneuvers you should perform in your office before determining where to send them. That said, they are very consistent in their identification that history and physical examination is not enough, and really part of this has to do with your relationship with the patient, the experience you've had, and whether or not they would be open to considering diagnostic blockade. I'm happy to go through some of these with you, but these are really straightforward. It harkens back to med school doing, inspection, palpation, percussion, although you wouldn't do that in the C-spine, or auscultation. But certainly the most important things are actually trying to load that C-spine joint, looking at their range of motion, identifying whether or not there's limitations, and that would be a reason to consider sending them out. And now let's go to the radiology site. Again, we're very lucky in terms of having really great access to radiology, but imaging is not always the answer. And in fact, consistently, when we look at radiographic studies looking at, say, patients with rheumatoid arthritis who have known degenerative progressive arthritis, when you take about 400, the study that I'm talking about with 50%, they took about 400 of these patients, imaged them all. They identified about 50% of people did have evidence of osteoarthritis and degeneration of the facet joint, but in that group, almost half of them didn't have any pain problems. The imaging really is not, it should not be a fishing expedition. It should be the other way around. It should help strengthen your diagnosis, but negative imaging does not mean that your diagnosis is necessarily incorrect either. So be very cautious. X-ray certainly has no real evidence in supporting decision-making as to where you should be organizing interventions. Along with that, MRI is notorious for finding lots of problems, but not necessarily finding lots of answers when it comes to neck pain or cervicogenic headaches. Facet joint hypertrophy may be present in most of your elderly patients, but they certainly may not be consistently identifying a pain problem or a pain problem that's consistent with your physical examination or your assessment of the patient. SPECT scan, certainly lots of radiology reports come back to me recommending a SPECT scan to localize the level of facet joint that should be injected. There is really good evidence for that in the lumbar spine. There is no positive evidence for that in the cervical spine. So don't be fooled into ordering a test just because you think that's going to help better localize a problem unless your clinical exam is suggestive of that. If it's not, then don't look for it. SPECT scans for the cervical spine don't really help identify facet joint targets. There's a lot of excitement about using PET scanning, another very expensive, complicated tool with limited resources. That said, the positive evidence on that side of things was really not in keeping with how we practice when we do interventional pain management. So they were using high volumes of local anesthetic, over 3 mils, which really is not consistent with what we expect for benefit for patients with pain. So certainly would not recommend sending your patients out. From a pragmatic perspective, if you are ticking off a box requesting RF neurotomy or something like that on a radiology scan, they will often request that there's an MRI C-spine be completed, and that's certainly within their purview or their practice. There is evidence that you can have abnormal anatomy of the vessels around the neck, but certainly not recommended by the SIS guidelines. So the recommendation really here is you don't really need to do any imaging unless you are looking for something else. Certainly if there's other things on your differential, order imaging as you normally would. So let's go into the conservative management side of things before we get into the interventional pain, because most of us have access to, and most of our patients have access to conservative management first. The first two studies are really looking at utilizing some level of spinal manipulation in the cervical spine. I don't think there's a lot of excitement for that now with, I think it was Caitlin Jensen in the US who unfortunately had a terrible outcome with tetraplegia after spinal manipulation. That said, the benefit of it has actually been shown that even utilizing exercise-based therapy in greater occipital neuralgia and cervicogenic headaches is effective in helping reduce pain. This, when we look at a cohort of patients at the 12-month mark, about 74% of patients will have reduced pain, reduced headaches, increased cervical neck range of motion over 15 degrees compared to, say, 5 degrees. When they get just exercise-based therapy. When we split apart the benefit of manipulation versus exercise-based therapy, there's no real difference in that. So while doing both together may be slightly more helpful, they feel that there's a 10% increase in patients that will get benefit. That said, a majority of patients will get benefit with just exercise-based therapy going forward for cervicogenic type headaches. That said, a lot of this is complicated because maybe those people would have gotten better without anything else anyways. That part is a bit not totally clear. It's not as well elucidated as it is in lumbar back pain. But luckily, there's also a Cochrane systematic review that has looked at this. There's really great, well, let me clarify. There's moderate level evidence that supports the utilization of physical therapy in helping treat cervicogenic headaches, especially as a conservative first-line treatment. And it's very reasonable to do, especially if patients have access to some amount of physical therapy. That said, when it comes to you seeing the patient in your office, this is kind of how I think about my patients, and hopefully something that you could consider applying in your own personal practices. So number one is if you think this patient has a cervicogenic headache, then it's not unreasonable to trial them on conservative management. This could certainly include pericranial nerve blocks. They're simple, they're relatively effective, they're relatively low risk, and you're not really in a position of harming the patient. And certainly our medications are probably worse when it comes to the cognitive dissonance, the cost, the kind of things like weight gain, dry mouth, all those things. Very reasonable for you to send them to consider seeing a physical therapist or any kind of rehab professional that they prefer. The next step from this would actually be a cervical medial branch block. So this is where there's a big difference in what most people will order, which is usually a facet joint steroid injection. But the recommendation here really is to use a block rather than a facet joint injection. And the reason for that is the risk of overall steroid exposure over the duration of that person's life, number one. Number two is really the evidence is suggestive of RF neurotomy being a superior modality, especially if your diagnosis is correct. So I would then go on with a positive block, and I'll talk a little bit about what a positive block should mean for radiofrequency ablation. Then failing that, consider sending your patient for a surgical assessment for possible surgical decompression or ganglionectomy. So the major procedural recommendations, these are more, if you're a proceduralist in clinic, these are what the SIS guidelines along with the ASRA pain medicine guidelines are, is that you should be using image guidance, either ultrasound, fluoroscopic guidance. If your patient is going to a clinic where they're saying, oh yeah, some guy just stuck a needle deep in my neck somewhere, pericranial blocks, different thing, but for image-guided spine blocks, they should be using some sort of image. A 25 gauge short needle is recommended unless your patient's higher BMI. They recommend specific approaches to avoid injuring certain nerves, depending on which level you're working at, lateral versus posterior approaches. The other thing that's really important is using very low volumes. Radiologists may not consistently do that, and that's where, when you get the report back for a patient that's had a procedure done, you can determine whether or not this was effective or not. The volume of local anesthetic should be less than 0.3 mils, so it's very, very low volumes. And in any intra-articular injection should be 1 mil. It's reasonable for them to get bilateral blocks, so if patients say, well, I don't know if I should get both sides done at the same time, it's reasonable to do bilateral procedures. However, should not be doing more than 2 levels at one time. And that kind of fits within our SOMB practice, so it's not something that while you can tick it off, the radiologist group will split it usually over a number of appointments. Now, really, what's the last thing? Yeah, the other big thing is really the big recommendation against intra-articular steroid injection or even perineural steroid injection in the cervical spine. So ideally not proceeding with that and using local anesthetic followed by neurotomy. The benefits of RF neurotomy are really quite clear. Most people will benefit from, can be between 6 to 14 months worth of pain relief. Often these can be repeated if needed, and obviously these are percutaneous, relatively easily accessible to most of us, and certainly is better than putting patients on chronic opioid therapy or considering surgery. There are risks which include neuritis, paresthesias, dropped head syndrome. This is when is very rare, but case reports have been identified for multi-level bilateral neck injections resulting in this, where they lose innervation to their extensor muscles in the neck, which can result in requiring surgery. So it's a very reasonable thing to caution patients on. And finally, ataxia. This is usually short-lived, especially in bilateral procedures. People might feel they're a bit discombobulated, but that will improve. Now, the last real bit that I want to talk about is surgical management and how you can access it. So I'm not sure in Edmonton zone or North zone, but certainly in Calgary and South zone, these patients can be referred to the peripheral nerve clinic, which is, there's one at South Health Campus, there's one at the Foothills Medical Center, often run by neurosurgeons and plastic surgeons alike. And if the major indications are if you have a patient that is refractory to all of these therapies, you've tried everything, you've sent them for nerve blocks, injections, procedures, RF neurotomies, and they're still coming to your office with terrible persistent pain that continues to be reproducible in the occipital area or you believe to be cervicogenic, and they have good blocks, as in you do local anesthetic blocks, they get great for a couple of hours, but then the pain comes right back when the local anesthetic fades. That's when you could consider sending these folks over. Rarely will they offer something like an instrumented fusion. It's a big operation, kind of splitting open the C1, C2 anteriorly. Often they'll offer something called a C2, C3 ganglionectomy. It's a smaller incision. They get essentially at the C2, C3 ganglion and just disconnect them. The benefit here is usually about 75% of patients have immediate pain relief, especially if that's their major problem. Often the pain relief is long lasting, up to 5 years. They may have to have a repeat procedure. These ganglion will grow back and re-innervate. And finally, consideration of peripheral nerve stimulation. Our neuromodulation program in Calgary is kind of a little bit haphazard, but certainly one of our neurosurgeons is able to kind of implant peripheral nerve stimulators into the greater occipital nerves if that is their consistent problem. But that's it for me, so I'll give this back to Dr. Becker, and hopefully we can answer some questions.